attendees are in listen-only mode.
Hello, good afternoon, everyone. Thank you all for joining us. Very excited about our special guest today. We have Neil Gomes, who's the Vice President of Technology Innovation and Consumer Experience at Thomas Jefferson University and Jefferson Health. And they've been doing a lot of, really diving into a lot of innovation, digital transformation, mobile apps, and really engaging their community of patients, physicians, and partners. So with that, I know you came to hear Neil and not me, Margaret Ramon Convey, so I will turn you over to Neil.
Hi, hello everyone. Can you hear me? Margaret, can you? Okay, perfect. Yeah, thank you for taking the time to join the session. I'm here mostly to tell you a story, and I hope it's an engaging one. It's something about the things we've achieved in the digital innovation space in an industry that you probably know as one that is not known much for innovation, which is healthcare. And we also happen to be an academic health center, so we've done some strides in the education area too. So, but I'll mostly be talking about our digital innovation in healthcare and how we've not just created great things, innovative applications and things like that, which I'll show you, but also created a culture of innovation at Jefferson. So that's really what I'm going to focus on. And I believe in terms of questions, if you have any questions, Margaret wants you to type them into the chat area, and then she will they will consolidate them, and we'll have a Q&A at the end. Is that right, Margaret?
Yes, that's perfect. Thank you, Neil.
All right, great. So I'm Neil Gomes. I'm the Vice President for Technology, Innovation, and Consumer Experience at Thomas Jefferson University and Jefferson Health. I'll give you some context of the environment in which I operate. We are based mostly in Philadelphia, although we are entering the New Jersey area, and we also have patients from all over the country and even internationally that come to us, so as well as students. So, so we are certainly not just based in Philadelphia, but our main hub is in Philadelphia. And we are very happy about that, because Philadelphia is a city that is known for its innovation, has a lot of talent, a lot of skill in the areas that we actually operate in, which are very creative design, application development areas. So here are some statistics in case you weren't aware of Philadelphia. I won't read them out, but we are, long story short, we really enjoy being in this city. Which also comes with some challenges, of course, because there are lots of other players like us in the area, which means that we have to compete in a very challenging environment. We, as Jefferson University and Jefferson Health, have been around and been in the Philadelphia area for a very long time. If you look at the last point in this slide, we were founded in 1824, so approximately a 200-year legacy, and we are quite proud of that. But it also comes some challenges. We have mindsets that are kind of very difficult to change sometimes if you want to change them for innovation, and at the same time we have a lot of innovation in our DNA, and so that's something to keep up with, and so it does challenge us in that manner. Jefferson is actually the second medical school in the nation. We are also known for gross anatomy, if you've heard of that. That was invented by Samuel Gross, who was a physician at Jefferson. And also, of course, the heart-lung machine, apart from several other inventions. So lots of innovation at Jefferson. And so we are trying to bring that similar kind of innovation in the digital space. There's also a lot of growth. Not a lot of people may know this, but Jefferson, when I joined 2.5 years ago, we were 3 hospitals. Now, 2.5 years later, we are 9 hospitals. By the end of this fiscal, would be about 12 hospitals. So tremendous growth in a very short period of time, which means that our solutions and things that we develop have a chance to impact a lot of people. So if you were looking to get into healthcare and education because you want to do something meaningful with your life, well, we just tripled that or quadrupled that, by affecting so many patients. 1.9 million outpatient visits, 350,000 ED visits, and 96,000 plus admissions with the current size that we're at, and about a $4.8 billion revenue. We're also a not-for-profit institution, and we have multiple colleges, mostly in the health professions kind of space, as you can see from the slide. I will go to the next slide. I put this slide in because I believe strongly that in areas like digital innovation and digital transformation that we like to operate in, none of that's really possible, and at least in the long term, unless you have very, very good leadership support. And we are fortunate to have that, and I like to always put this slide up in front of people because it's extremely, extremely important, to have leadership behind you, especially when you're using design methodologies to promote innovation. Very few people may sometimes appreciate that and may see the value in it, until you actually make something that delivers tremendous outcomes. And we've done that, but in that journey, the leadership helps you in supporting you, in having the patience, and encouraging others to have the patience till you realize those goals. And that's the reality of it. If your leadership doesn't support you in that, doesn't provide you with the types of funding, almost like a VC, funding various different projects in this case and various different initiatives, then you don't have a place to go, and the culture does not change, and we are lucky to have Dr. Steve Glasgow, who's that kind of transformational leader and believes strongly in technology as a way to transform both healthcare and education, and also design principles and consumer experience and consumer-focused solutions in doing that. So here's a little bit about my team, just to give you additional context in the environment that I operate in and the investment the institution has made in having a team like this. None of the people that are on my team existed in such a team before, and in most other healthcare organizations do not exist, because resources are constrained, and they are constrained for us here too, which is why the way that we've constructed these teams, there aren't too many people that we've hired to do this kind of work. We've relied a lot on our existing personnel. We've strategically hired different team members onto these teams that I created, but a lot of the folks on the teams are actually people that we've reskilled, that we've enabled, because a lot of them had great skills, but without that innovation mindset, sometimes people don't think they're allowed to do certain types of things, and we've broken through that, I feel, in many ways, and enabled people to think different and do different. So so a little bit about my teams. We have a design team, because we believe that design is how it works. It's not just about how it feels or how it looks, and we like to change that to design is how IT works. And that's actually a Steve Jobs statement. Give him credit for that. And our design team really guides a lot of the development, guides it from the user's perspective, from the consumer's perspective, as well as from our own perspective in terms of what we learn through research. So that's a very, very important aspect of our teams and a very important principle. The application development teams, our design team, by the way, in terms of size, is a very small team. It's about 8 to 10 people, and we have a fluctuation there because we also employ clinical fellows on our team, medical students. These can even be physicians. We actually have one physician right now that's working with us as she does a research internship too with a research fellowship too with Jefferson. So And the reason why that's important is because it gives us the right context when we're developing solutions for physicians or even for patients to have that different that insight, and that experiential insight from such people, so that we're not developing in isolation of that. And then we, of course, have the creative development team. We call it Innovative Technology Solutions and Platforms. And our fundamental principle there is agile or nothing. We also treat ourselves like a lean startup. And we have actually 12 principles that guide all of these teams that we feel kind of act as the glue and the decision-making tool for us sometimes when we do have decisions that need guidance or that we need to make really quickly. So these teams, the application development team is about 25 to 30 people, but they also do a lot of operations tasks. So it's not just a team of people that that are solely developing new applications. So we manage the, for example, we manage the all of the web properties at Jefferson. That same team. We manage platforms like SharePoint and Confluence and Jira and all of that. So they're a multi-purpose type of team. While doing operations, at the same time, they also focus on creative development, which also attracts a lot of talent to us. And then, of course, we have the innovative education team, and these last two teams, they're strategically included in this group because we believe that it's not just good enough to have to have a development group that develops solutions, a design group that helps design them and guide development. It's also important to close the loop around what you develop and make sure that you are providing the support so that the solutions that you make propagate across the system. You are changing the mindset of people, and then you're training them in the new solutions that you're providing, so enabling them to actually use them, and at the same time also supporting them in their use so that they continue to use them. Many times we create great solutions, but without the right type of support, people don't use them into the future. They revert back to what they were doing before, and then it's a huge loss to the organization and as well as to your team. So we don't want that to happen. Give me 1 second while I just quickly escape out of the presentation because it's not. Hang on. Okay, I'll go back. Sorry. You can see my screen, right? Margaret, is that good?
Yes, we can. Thanks. Yes, we can, yeah.
All right. So I'll quickly go to a quote from Larry Page, and because this kind of inspires us in the way that we develop consumer-focused solutions, right? I mean, he said, I'm sure after he had a bad experience maybe with healthcare, that if your access to healthcare involves you leaving work, driving somewhere, parking, waiting for a long time, that's not going to promote healthiness. And many times you forget that. Healthcare is the one industry where people will tolerate all of that. Right? I mean, you won't tolerate it when you're buying stuff online. You won't tolerate it when you're, when you're trying to do your banking online or purchasing a flight online. You won't tolerate all of that. But in healthcare, you will. One, because you feel it's only something I'm going to do once in a while. Two, you also feel that, oh, well, the value associated with this is tremendous. And three is because, that's just the way it is, is what many consumers think. But it doesn't have to be. It doesn't have to be that, and we don't want it to be that for our consumers. And so we've kind of, this is our driving force behind all of the things that we do. And so you'll see that in the applications that I'm going to show you in a bit. And from an application perspective, the ethos behind our solutions, we want them to be consumer-centric. We want them to be innovation-driven. We want them to be mobile-enabled as much as possible. And we want them to be cloudable. So, in that we create these ecosystems where not only the data resides somewhere else rather than on our properties here, which has a lot of benefits that you obviously know, but also that you can then create ecosystems for sharing that data, working with other people that are way more open to working with you when you're not the one owning that data, you know. So the cloud also enables us to do that kind of work. And Convey, of course, is one such platform that enables us to do that. All of these things really focus on the consumer, create innovation-driven solutions. Mobile enable them, of course, and then it is in the cloud. So it's a great platform. I'll talk a little bit about Convey a little later, but just quickly to run you through some of the solutions to prove to you that there's some metal in what we are talking about here, and that there are some real results behind this. We developed an application called MyJeff Health for our hospital organization. We did this in rapid time, and that's another thing that we do. We try and develop these solutions really quickly, not in a substandard kind of way, but the ethos that we have around lean startup and agile development, that guides us into developing things that are focused on delivering the 80% of value that people derive from 20% of an application. So we develop the 20% first, release it, test it with our consumers. In fact, this application is already in its second phase of design. If you go to the Apple App Store or Google Play and try to download this app, it doesn't look the same anymore, because we collected a lot of feedback from patients in the first round of after the first release, and then redesigned the entire application so that they could benefit more from it. It looks aesthetically more pleasing as well as functionally more effective and intuitive. So we're very, very consumer-centric about the solutions we develop, to the point where we took a lot of the feedback we received from patients, and one of the things that almost all of them said to us was that you have to a little bit understand our situation at Jefferson and the city here. We're not like a traditional hospital system, where you come to this one place. Like if you're in Florida, there'll be this huge hospital, sprawling across acres, and everything would be in this one building or maybe two buildings. Here we have multiple buildings because it's a city, and the way we've grown over 200 years is that different facilities are in different areas. So it's a little bit difficult to get around, to find the right place. We cannot use a lot of billboards and things like that to guide people, because there are rules and regulations against those types of things. So we found a digital way to do this. We tried beacons, we tried other types of Bluetooth technologies and Google-based mapping and whatnot, but the confounding factors for us were always, oh, we're inside a building, so you don't really know which floor you're on. If you try to use beacons or Wi-Fi, there's lots of maintenance behind that, being able to determine what floor a person's on and what services they're trying to access. So we made it very simple. What if we didn't have to deal with any of that, right? What if you were a user and you want to get somewhere, the only piece of information you really should need to know is which physician I'm looking for, and we already know which physician is where and what location they serve. So that's all we ask you with the Journey to Jeff tool, which we are in the process of developing. So if you download the MyJeff Health app, you won't see Journey to Jeff there right away, but it will be out before the end of this fiscal year. So because there's lots of data collection that we have to do, and I'll explain that in a bit for it. But basically the experience is that a patient comes in, they say, okay, I'm going to see this doctor, so they pick the doc from the app. It then asks them which location are you going to, because some docs are in multiple locations. They pick the location. It asks them, how are you getting here? If it's train, then it gives you train schedules. If it's if you're driving, then it will give you parking information, the directions, as well as if you want food, you can say, okay, well, I want food around the area. It will give you that too. It's all location enabled. And then you can save that journey, share that journey with a caregiver that might be taking you or someone else that's taking you to the location, and that way it makes it extremely easy to find a place that you need to get to without even sometimes needing all the high technology stuff like beacons and all of that. So that's one innovative kind of thing. And then of course we have our Jeff Connect application, that is our telemedicine application. which we use American Well and Teladoc in the back end, but in the front end, all of this is run by our own docs, by our own technology systems. We customize the application, and it's evolved into a national brand where anyone can see a doc at any time on Jeff Connect for a very low cost, and a lot of people do. So that's another consumer-focused innovation that we have. This is something that's won us recently the CIO 100 award, and basically the ED team, when some new leadership was hired, came to us and said, look, we really need to increase the throughput in the ED. So we think that you need to help us redesign our EMR front end, because it's not giving us the right information. It's very confusing and all of that. So this is a great example of how we use the design process to inform whether we should do something at all. Okay, so many times folks come to us not with a problem to solve, but with a solution. And they say, okay, well, we want you to do this for us, right? And one of our principles is, if anyone else can do it, then maybe anyone should, right? So if they come to us with something that they feel like, oh well, we know exactly what the solution is, we want you to just implement it, and that's an anyone could kind of situation. So we like to take a step back, and first, before we invest our time, which is also valuable to us and the organization, and it's precious time, right? The organization spends a lot of money on our teams, so we want to be sure that we are using that time effectively in ways that will benefit the organization, benefit patients, and if we can get a win-win-win across all three, then that'd be great. So we ask these questions. We ask for access. So with the ED, we said, oh, this is great. Thank you for coming to us. We would like to help you out, but we have a few conditions. One, we want to test the hypothesis. We want to be sure that we are addressing the right problem and to get the outcome that you want, and that the solution you're bringing to us is the solution we should develop. And so they were open to that. So they allowed us and our developers, not just administration or anything of our teams, our developers, to spend days in the ED, almost in an ethnographic research kind of situation, looking at what the problems were in relation to throughput, why patients had to stay longer or as long as they were staying in the ED, why we couldn't get them through if they needed to go to the hospital faster, if they needed to go home faster, and then also how to get them to a provider really quickly, because then the decisions can be made a lot more quicker. And at the time, I will show you quickly some of the stats. At the time, we had about a 4.6% left without being seen rate in one of our EDs, our largest ED in Center City. And we employed some of the solutions when we came out of this process of being in that ethnographic kind of situation. We realized that it's not really a question about interface design or anything of that sort. It was really about movement. It was about getting people in the ED to move. ED being the emergency department, some of you may refer to it as the ER. We needed them to move from one state to another, so that they did something for the patients if a threshold was breached. So we helped the clinical teams one by one. These displays that you're seeing here weren't just developed overnight. In the initial phase of agile development, in the first 2 weeks, we delivered 3 of these displays that we thought were most important to them. And along with their feedback also, of course. Immediately in that first month, after 2 sprints, they reported the left without being seen rate going down to about 1.2%. Now it's at 0.8%. When you think about that, just that one ED, there were 60,000 patients that we see there per year, and to go down by that much, it may seem small, but in terms of patients, that's nearly 2,000 plus patients that we now see more than we used to see before, that aren't leaving, that we can take care of. And also in terms of revenue, it brings additional revenue to the organization. But this is a win-win-win, right? I mean, we have a great story to tell, and we've affected the care of a lot of people. The patients are being taken care of, and also the organization sees some advantage from this. So we even reduced the average length of stay for discharged patients by 42 minutes. These are patients who got to go home 42 minutes early on average. Average time to a physician reduced by 23.9 minutes. We were down to about 18 minutes to a physician. Before it was much, much longer, 36 to 42 minutes. The scores from Press Ganey, which is a patient satisfaction metrics collection company, showed Jefferson's ED patient satisfaction score of 82.2 on a 90-point scale, increasing in 6 months to 84.5 after we implemented this methodology as well as process, which they said no other ED has ever achieved such a change. It may seem small, but to get from 82.2 to 84.5 takes a lot of effort usually in most EDs, and also requires you to hire a lot of people so that you can provide that level of service. We hired no additional people, we didn't let go of any existing people, and we still achieved those same metrics. And the way we did that was create applications that presented the data that people needed to make things move very rapidly in front of them, almost like an agile board or backlog being presented right in front of them. And so the ED installed these boards, these digital boards, which basically very large screen monitors all over the ED, like there's 7 of them just in one of our EDs. Then our solution got implemented in the other EDs at Methodist and a slightly different variation at Abington. So, and also we built comms on top of this so that if certain thresholds are breached, and algorithmic thresholds also that are a combination of other thresholds are breached, information goes out, or communications are sent out to administrators via text, email, whatever they prefer, so that they can staff up the ED, they can staff down if in case it's a negative threshold or reverse threshold, and also thereby saving money or creating a better patient experience if more people were needed. And also they could go out into the ED because many of them are clinicians and alleviate the pressure if it was saturated. So and this rapidly, right? I mean, because we're working directly with, we're not making this into this huge project, we're taking it chunk by chunk and getting achievements throughout. That also keeps the momentum going. People are happy to see results. They feel motivated, and they're not waiting for this thing to happen after 6 months or 1 year and lose the enthusiasm in that time and never really achieve the end result. This is another example of an application we created and then created into a data display inside this product called Domo. This application, the problem was that people were spending way too much time, or people were waiting way too long to get authorized, an insurance authorization for chemo. It was taking nearly 22 days, and most of the folks in the department itself said that, well, it's the payers take way too long. So we created a latency application, that almost like a workflow application that the people that were part of this process had to access, using also some triggers from the EMR, so we didn't make it too laborious for them. But whenever they moved from one state to the next state with the application, we could measure when that change happened. And we found out that 13 out of the 22 days were actually within the clinical department itself, and only 9 days were with the payers on average. The longest time a payer took was 9 days. So So we decided, okay, we got to solve this problem first internally, and then we gave the physician actually this chair. You can see it where it says the number 4 in the top, the small little box there. We told him which physicians were taking longer. So he had the physicians that are taking less time talk to the physicians that are taking more time in order to move things through, their admins, their nurses, their other clinicians within that group, and got them to incorporate those kinds of methodologies that they were using to move things faster, right? So that way we dropped it down further. Then he went to the payers and said, why are you taking so long? And they said, well, it's because you're not submitting complete documentation. And so we showed him which physicians, this is the left bottom corner one, which physicians are not submitting complete documentation. And he did the same process, dealt with it, with actual people, in their staff meetings, correcting these problems. And then finally got it down, as you can see on the averages in the last year now, down to 3.3 in some months, days to 5 days max in some months. So from 22 days down on average to about 3 to 4 days is a tremendous, tremendous achievement. And also it brings in, not only does it make patients happy, get them to heal faster, but also gets the organization to earn more revenue. Because these patients could have were going to other institutions, because if you're diagnosed with cancer and you're told you need to get chemo, you're not going to wait 22 days, to do that. So, so we were losing some patients. So this is some of the metrics behind that. I won't spend too much time on this, but we had the Pope coming to Philadelphia, and we had to. Our clinical division was trying to manage the logistics of housing people, because we had to house a lot of our staff in the city, in our buildings, for 4 nights, because if they left, they wouldn't be able to get back in because it was a controlled zone. And so we had to house them here, 2,400 people, more than the top 3 hotels could house in the Philadelphia area. We were housing those many people, and the logistics behind that were tremendous. We couldn't manage it in like Excel files or things like that, so we created an application, a hunting and searching kind of algorithm behind it, that all you had to do was pick the person, and based on a lot of variables, their gender, the food type, food that they prefer, their location of service, their type, their team members, their sex, it would automatically assign them to rooms and locations, and you could make changes on the fly using an iPad or other type of computer very quickly. So that's another weird kind of thing, right? You wouldn't think a health system would need something like that, but we're open to making those types of things, because especially when we know we can use it in an emergency situation or some other kind of situation, and it would add value. Margaret, are there questions? Am I okay on time? Do you need me to speed up? I feel
you're doing great. You're doing great.
Okay.
I think your content is incredible. Thank you so much.
Yeah, thank you. I just want. I don't normally. I'm always hearing. I'm used to being in a room and seeing people react. So this is a little bit different. I hope I'm not rambling on with anything that's irrelevant. So the other part that space that we operate in is the mobile space, right? So we have a lot of existing applications that we deploy, like Jeff Connect, for example, with Amwell, American Well, and Teladoc in the background. A lot of things that we build on platforms. A lot of things that we build custom, in native languages like iOS and, for iOS and Android. And also a fundamental principle behind all of the things that we develop, not just mobile, is that we don't make something that already exists, that we could have got through, let's say, purchasing something from a vendor, unless there's other economic reasons. If a vendor's charging us way too much for something that we know we could develop for a lot cheaper and in the long term would generate economies of time and scale, then we develop them sometimes. But most of the times, if there is an existing solution, we try to negotiate, try and get that solution in. So we don't want to recreate something that already exists. Now, a lot of healthcare organizations have, through their EMR companies or even externally, they have applications for patients, like a patient portal that is also mobile. So we didn't want to recreate that, because we know we didn't have one here that was very effective, but we were going onto a system that was going to provide that, and we now are on that system. It's called Epic. So we didn't want to create another Epic MyChart, so But we found a very, very dire need that was expressed to us by clinicians mostly for these journey kind of applications. That's what we call My Baby at Jeff. These portable solutions, what they do is they focus on a generic healthcare consumer or a patient, right? Where they try to meet all of those people's needs, sometimes effectively, sometimes not. We learned from our clinicians and even from our patients that certain types of patients want their journeys with our system managed in a certain way, where they get the right type of information, they get not just education but also reassurance, the ability to connect with their care team, the ability to find them all in one place, the ability to connect with other people that have the same kind of healthcare situation or problem. And so the first one that we created was called My Baby at Jeff, is focused on the pregnancy journey and the journey of having a child. And we wanted to do that first because it's a very positive journey, and so we created this on a platform called Mobile Smith. Now we are migrating it to a native platform because we want it to be both in the Android and the iOS space, and we also want more control over it. And that's an evolution many times for us. We develop some things on platforms that make it very easy to make an MVP, a minimum viable product that we can get out into our patients' hands right away, so that we can immediately start researching its use, finding out, do they like it, what else would they like to see in it, in a way that is cost effective to us, so that, because if we try to develop everything from scratch, the patient, it would cost us a lot, it would take a long time to test, and then we might realize at the end of that period that, oh, well, the patients really didn't like it or don't want it, or the physicians don't like it and don't want to use it with their patients. So we develop rapidly, sometimes on platforms, and then we migrate. If we find it to be successful, we migrate it away from a platform into a more controllable environment, which is what we did in this case. An app that is now being used, and this is another economy that you realize many times when you're a larger health system, is that, and when you're growing, is that once you make it for one place, like the OBGYN group here at Jefferson, now our other health systems like Abington wants it, and ARIA wants it, and all of these other systems then say, okay, well, we'd like it for our OBGYN group too. And that way, sometimes, many times, you save. In this case, we could have purchased other apps that already exist and that cost quite a lot of money, but by spending the time that we did, which in itself was less than the cost of some of the licensing, we not only saved the one-time cost but also the annual fee that we would have paid to some of these companies to license this. This is another such example called administrative rounding, but this is really a consumer-focused effort, not just an application, but even the whole process behind it. We had the clinical pillar looking at some pre-built applications that did administrative rounding or enabled administrative rounding, but again, in this case, the cost for those was very high, so we were able to develop this in about less than 3 months, really, with just a couple of developers on it and working with the clinicians. And what this enables is a real agile kind of process that the clinical pillar engages in, all focused on the consumer. So what they do is every Friday they take these apps, which are, and they use iPad minis, and the app is running on the iPad mini. They meet on every Friday, about 123 people meet, and they, on average, and they are then triaged out to all the facilities, across Jefferson. They meet with patients. They go around the facilities and see if there are problems, like if a bed is damaged, if something looks dirty. They take pictures. They triage the issue directly to the right space, so they don't even have to, take that and then afterwards put in an email, send it across, or anything. All of that, the ticketing kind of is built into the application. They can follow up with the people that were supposed to do it, which they do. They do a retrospective before they, not just a retrospective kind of, using that terminology, but what they basically do when they start their 2.5 hours on the Friday is first they look at all the issues that are pending, that weren't resolved, and then issue reminders for that. Then they go out and get triaged into different areas and collect more information. The advantage of this is they go to patients and actually talk to patients, right? Many times, most hospitals that operate and have patient experience offices operate on data that is gathered for them by a third party like Press Ganey. And then they get that data after the patient's discharged, sometimes 3 weeks, sometimes months later. So there's no way to really say to a patient, look, I really care about you, and therefore I want to hear about the problems you're having and try and solve them while you're with us. Sometimes these folks go out and meet the same patient the next week, and the patient's telling them, oh, thank you for solving this problem. And we want to use this system to even get more innovative with it and enable building automation systems to be managed through the platform itself. So if we wanted to increase the temperature in a room because the patient said, oh, it's so cold right now, they can do it right off the app so that it's instantaneous. So that's the administrative rounding application. We got some great feedback from our president of the hospital system at Jefferson. In 6 months, they had about, as you see there, which was 125 enterprise leaders, surveyed more than 1,194 employees, 864 patients. Now those numbers have actually increased. This is about a month and a half old. The Senior VP and Chief Administrative Officer of our Methodist Hospital said that it has actually increased their HCAP scores. It has helped them go from all of the 3 hospitals in the Center City area to go from a 2-star rating in CMS to a 3-star rating, and he says that this system was one of the major factors in making that happen. Am I doing good on time? I have a few more minutes. I want to be sure I have enough for questions, so I'll quickly go through the rest of these, okay, in about 2 minutes. We also created a ResearchGate application in about 3 months. There are only about 14 ResearchGate applications worldwide. This is the Apple ResearchGate platform. We did it in about 3 months, which no other institution has done it that rapidly. We think that's a great thing, and now we can use that learning to develop more ResearchGate applications for other researchers. This was a very large study that was funded by the NIH for prostate cancer. We are using the Convey platform and Google Cloud in the back end for storage to develop a lot of our cloud applications. One such example is of the President's Dashboard. We had our President's office come to us and say, hey, you did a great job. I didn't show that example, but we did a great job on the Enterprise Dashboard, where we created a dashboard for the leaders in the organization to follow certain performance metrics across the organization towards what we call a blueprint for strategic action. So they liked that, and they now wanted us to develop almost like an Asana, if you ever used Asana, for the President's office. So we did that, and they used that. And we built it on Convey in about 3 weeks, so very, very rapidly, from prototyping all the way up to actual use. And the advantages of using a platform, we feel, like Convey and others that we use, is that if you could certainly try to make the application on a native kind of platform, where you're designing for iOS, let's say, in native environments. But then you, one, spend a lot of time doing it because a lot of the stuff is not repurposable. None of it is pre-built for you. So it's like literally like building, with a car from scratch in your garage, right? Great experience if you want to get into it and you have a lot of time, but not so good if you want to deliver value really quickly in a manner that's well managed and secure. So we use platforms like Convey to develop HIPAA compliant apps, because we are a highly regulated industry, right? Which is why innovation kind of suffers also a little bit in healthcare. But we like to find ways to still be innovative within those regulations, stay responsible to our patients and our patients' information by wrapping it in these types of platforms that take care of all of those parts of the ecosystem that are really, really important, right? I mean, we need the user experience to be seamless across different types of devices, our client devices. We want for our developers to create an environment where their code is reusable, where they don't have to worry as much about security and being, from their perspective, and it being a kind of blocker for creative thinking and the why nots and what ifs kind of that they come up with, So we want the platform to handle that as much as we can. So so Convey and other such platforms enable us to do that. I speak a lot about Convey because our developers are really happy with developing on the platform. We allow our team to decide what we want to, what platforms they want to develop on, and they glommed on to Convey like bees to honey. Because they felt they were really well supported by the teams. It is a well documented platform, so for them that's really, really important, because they don't always want to have a condition necessarily with someone to figure everything out. They want to try and do it themselves, use the self-service mode for development. And then, of course, the enterprise itself, is very, very concerned about putting things into the cloud and, want that security of a BAA, but not just something on paper, but real care being taken about the data that resides with them. So that's what platforms like Convey provide to us. That assurance, as well as that actual care for your data, because it matters to them too, and they're invested in your success. These are some of the things that guide us in what we do. We feel like we can develop the future now by focusing on accelerating clinical and academic processes through design methods and creative application development and support and training that surrounds all of that. We want to help with these applications to build competitive advantage and, of course, also increase earnings. It's because and we feel like we can, we know and we've seen it happen, that you can achieve all of these objectives while being useful to the consumer. And we try to operate at that intersection. Our equation for digital transformation is very, very simple. We try to break things down into very, very simple kind of things, because too much of development is I say, over complexified. It's not even a word, but it's very, very simple for us. We want great teams, and great teams not just us, but also developing in collaboration with the folks that will ultimately use these solutions, clinicians as well as patients, as well as their community, the patient's community around them. So we pick these people that work with us very, very carefully when we're working on a problem and trying to find a solution. We also spend the same amount of time picking the right types of platforms to develop, because we don't think we should be the central hub for innovation. Innovation should not be the currency of a few, as I've said many times, but the combined wealth of the many. And that way, you can sustain it for longer. It's like what Apple did with apps, right? And creating an app store and enabling the platform to thrive because other people are developing on it and being innovators on it. So we want that to happen within our ecosystem here. And then, of course, pick the right types of partners, be it Google, be it Convey, be it others that we work with, IBMs of the world, and a lot of startups, like Convey, that we work with, because we want those folks, and we spend a lot of time picking those folks too, because we want only those that are invested in our success. It's like Diane Green says at Google, is that I've never been in an enterprise where customers are your partners. We want the vendor to be our partner. They have to succeed when we succeed, and they have to believe that very strongly. And we have various ways of testing that metal and their metal. So, we do that. And those that kind of go on that journey with us are the ones that we stick with. This is the same President's Dashboard that I mentioned. And the closeness of working with Google and Convey in this situation. Diane Green actually spent a lot of time with us while we were at Google HQ. And then the things that I want to be sure that I get some concepts also out to you. I've talked a lot about stories and the things we've designed, and also some principles that guide us through this process. But I wanted to bring things together and help you understand, that in our situation, at least, in a lot of places in healthcare, this we always think that, oh well, we can use the same thinking to solve some of our problems, right? It's worked for us in the past. Why should we have to learn from some other industry, or that's kind of dangerous. Why should we get into that space? The whole cloud thing, mobile, maybe it's not for us, or we should just employ someone else's solution and wait for someone else to figure it out. And I always say that what got you here will not get you there. It's not my own statement. It's used by a lot of people. But industry is changing. There's huge disruption happening, especially in healthcare and education. And other industries have already gone through this, and they've evolved and they've come out of it. We have to do the same, and we have to learn from them. We have to not always ask somebody or an innovative thinker when they come to us the dreaded question, in my opinion, oh, so who else has done this, which is what we always ask many times, vendors or startups that come to us, and say, oh, who else has done this, because we've got to make a case to legal or something like that. Well, if somebody else has already done it, then we're not being innovative. So we've got to think outside the box, and also rely on the people that are inside the organization to think outside the box, not just outside. And then do this immersive type of development, design-focused, immersive development, where the developers are aware of the environment for which they are developing the solution, and do it cohesively with them. And then, validate the problem. I mentioned this before, or find the real one in case they haven't found the real problem, and then only devise a solution. Devise it rapidly, then build it rapidly. Test it, iterate, rebuild. That's very, very important, we think. And finally, a little plug for IT. A lot of people see IT as a cost center. One where a lot of money flows in and no money comes out of. No value comes out of IT except in operations and keeping systems running and that kind of thing. Something we have to do, we're forced to do, and stuff like that. We see that as not being the case. Technology is a driver of change, we think, and it is a real change agent. Information is a catalyst for change. Technology is a driver for change. And then I think Scrum is a good framework for change. So these are some of the things I'd like to leave you with. We haven't got so close to Google that Sundar has told us how he does this. I really like this quote. It says, I have a secret project which adds 4 hours every day to the 24 hours we have. So I wish we knew that, but we do some of these things without without knowing that. And we never forget that we are human, first, and that our humanity is best realized in the service of others. And this principle really brings us not just a lot of good talent, because what we do is so meaningful. We're in the two spaces where you can give more than you get, so education and healthcare, so if you're really looking for meaning in your life, then this is the industry that can provide it, and these are the industries that can provide it. And if there are any questions, I know I have left about 6 minutes. I apologize, but I wish I had more time, and I can stick around if you need me to.
So, all right. Well, thank you. We'd certainly like to open it up for questions. If you have additional questions, put them in the chat window, please. And I have one here for you, Neil. Clearly, you're well down the path of delivering digital innovation at TJU. But could you tell us a little bit about the journey that you took? What are some of the challenges that you faced in getting the culture to change and think more about innovation? And how did you overcome them?
Oh, yeah. So the journey was, it certainly was a rapid one for us, because at Jefferson there was, it's, as I mentioned earlier, an organization that has been around for a long time, right? So you have to break through that thinking that says, oh well, we've been around a long time. Why do we really need to, innovate a lot? This is all some cool hype kind of, and how do we get beyond that? So we had to change that. How we did it, part of it was leadership, leadership saying, okay, well, we believe that this is the way to go, and so that mindset helps change that. But it's not just top down, okay? It's also the kind of energy that you create within people and teams, where if they were to come to you with a problem, instead of traditionally like most IT does, when you're focused on okay, well, I have got to keep this organization running, I have to focus on operations, I have to make sure that everything runs smoothly, I cannot participate in this innovation space. If that's the mentality, then nothing much happens. You run a very good organization, and operationally you're great, but innovatively and in a competitive kind of environment, you're not. And sometimes you get swallowed, after some time by other larger organizations. So we didn't want to be that way. And none of the people, once they were empowered to come to a group that is, can help them with developing applications, we had the reverse problem, where people were suddenly felt enabled to do this just by the messaging, and then had an actual place that they could go to, or people they could talk with to enable some of these solutions. Sometimes to even refute them, that, oh, well, yeah, this is cool, but not really, doable, or maybe there's not much value in that. So we had to create a lot of sifting mechanisms to reveal to people very quickly that an idea may not be something we can do right now, or may not be something we should ever do, in a way that was responsible, that was respectful also. So all of those things contributed, but the biggest change factor was just the messaging, saying to people, look, we want to innovate, but we don't want to innovate just by setting up an innovation group or something like that. We want to innovate through you. So we want you to start thinking about those uncomfortable moments you have day to day, or that you see your patients or students having day to day, and then come to us and tell us about it. Right? And yes, we as an organization have these specific areas that we want to improve, like let's say the ER, or throughput in the hospitals and those types of things. But and so you can guide some of your thinking based on that, and there'd be higher value for some things over others. But overall, we just want you to change your mindset, and we want to enable you to do something with that. So that's really the main thing, I think, that changed, that got us to be more innovative, kind of. I hope I answered that question.
Yes, that's great, Neil. Thank you so much. And we've kind of reached the top of the hour here. So everyone, thank you for attending. And for those that didn't attend, we'll be able to have a recording out tomorrow, because I think, Neil, this has been the content that you provided, the insights you provided, and honestly, the philosophy in helping people really see a different way of thinking about it has been fantastic. So we really appreciate you coming and sharing with everyone. Thank you.
Thanks, everyone. Yeah.
It's 4 o'clock.